of opaque system. That was the aim of our study, to find out if it is accurate, and if it is not accurate, can we do something else to make it more accurate, and what is this intervention, and we did actually change the practice in our trust. How we did that? First, there was a meeting with one of the lead of the rhinology in our department, consultant rhinology, with a clinical lead coding group, and they extracted the whole opaque system that is used for interpretation, and there was some training to 2 ENT trainee in the department how to use it, and we developed this standard document, and we call it multidisciplinary standard document that used to evaluate if the accuracy that was done by the clinical coding is correct or not. So after the training, the 2 ENT trainee independently looked in the operation note in a period of time and to do a cycle of assessment if the accuracy from the clinical coding department was good or not. And we managed to get the same report also from the clinical coding. We did it in 2 cycles. The first cycle, we ran it from May to August 2017, and the second cycle was from September to December 2017. When you look to the OPS O, that was the original coding, was got from the clinical coding department, and the one with S is the standard after we reinterpreted again by the 2 trainees who were trained how to read the clinical coding. So this is how it looks like, the clinical coding. I want also to explain something called health resource grouping. Health resource grouping, when we collect the codes from opaques, and for example, if you are doing middle metal antrostomy, it has a code. If you are doing anterior smodectomy, it has a code. Both of them into combination, it can interpret into a common HRG, and that common HRG can be transferred into a corresponding tariff to fund from the financial department. And it's important to get this translation because that's common pool from other specialty to get the same coding, but it's different opaques, but you can have a common coding of HRG between all departments, okay? And this is how it looks like when we put it in the operation note in the second cycle. So the first cycle, when we run it, we didn't put any sticker in operation note, but just to compare the 4 months, what the clinical coding did and what we did. And in the second cycle, we put it in the operation note, and we're just ticking the boxes in addition to adding some of the operation note, and we try to find out if it is better accurate result or not. Looking to the finding of both, there was 2 rhinology firms in the department. One of them who used this sticker in his notes, who was the one who had the multidisciplinary team meeting, and the other consultant didn't use it. So we'll try to compare between the 2 firms. And the consultant who used it, he didn't use it for all his patients. He used it for a pilot study in his own patients. So even in his firm, he had a group of patients that he didn't have it, and he had a group of patients he had it. And the reason that he tried to do that pilot study because he had interest in rhinology and anterior skull base. So all his operation has a bit of complication, complex encoding. And that's why he was very keen to assess his coding is correct or not. Yeah. So for the result, we find that there is the accuracy in the second cycle for that consultant, which is blue, is getting better than the first cycle. But interesting, it wasn't significantly different between the first and second cycle. But it still made a lot of difference for the second firm of the consultant. When we measured it, there was some of the inaccuracies. Some of them was over-coded, some of them was under-coded, some of them was wrongly coded. And finally, just to we can see some of the bias in that study that we did as a pilot study, so we plan to do a 3rd study to make it more accurate. And we find that this is really helpful in increase the accuracy of the clinical coding in our department. Thank you.
So we have half a minute for questions. So I'm going to just ask a question. You refer to my paper here, which is Norai.
Yeah.
So we actually found that with underpayment, but you've got overpayment.
Yeah.
Keep it. Don't tell them. You can make your money. This is interesting.
Yeah, the first cycle was overpayment by 112. The second cycle was underpayment.
Okay, thank you very much.
Thank you.
Go to the next presentation. Timothy Williams. You have Timothy? No. The streamlining tonsillitis. Wow, interesting. Okay, we'll go for the next one then. You're paying one?
Put VJ on that.
No. HDMI.
Let's try this cable. Just going to use pop that in your pocket as well. About which one? Pop that in your jacket.
Can work. Oh, okay. Which is the laser point?
We've not got a clicker because that's attached to the computer.
No, I need the laser point.
Oh, laser point.
Where? Hi, good afternoon, ladies and gentlemen. Firstly, I would like to thank Professor Karashi and the organization team to invite us to attend this nice conference. My name is Wang from Beijing Friendship Hospital, affiliated to Capital Medical University of China. Today, I would like to share our data about the local drug delivery into the inner ear by canalostomy in the neonatal mice. So the inner ear involves the cochlea, the vestibule, and the semicircular canals, which are in charge of the hearing and vestibular function. Impairment of those organs result in sensorineural hearing loss and vestibular dysfunctions. Some of the diseases involve both systems, which show the both hearing loss and the sensorineural hearing loss, and those diseases are congenital and such as the Usher syndrome, which is we frequently see in the clinic. So to treat those congenital cochlear vestibular diseases, genetic interventions must be targeted both organs and in the earliest development stage. And on the other hand, we know that the inner ear is relatively isolated from the temporal bone, and it's a fulfilled with endolymphatic and or the paralymphatic fluid. So which is ideal target for the local drug delivery, because when we inject the drug from one side of the inner ear, it may distribute to the other parts of the inner ear. Recently, several papers have shown that cochlear gene therapy through the round window membrane or the scala tympani or scala media in the neonatal stage successfully restored the hearing loss in the genetically deaf mice. Here is several papers which is we use the virus harboring the V-glut3 gene, and this one use the KCNQ1 and also the TMC1 genes. So, however, few studies have focused on the treatment of genetic cochlear vestibular diseases. So, to better understand how to treat those diseases, an optimized traumatic delivery approach and an effective vector must be developed. So our group have shown that the adeno-associated virus serotype 8 vector have high tropsins in both the cochlear and the vestibular sensory epithelial cells. And in adult mice, we already have shown that the drug delivery through the posterior semicircular canals, which also named the canalostomy, achieve extensive drug distribution in the both cochlear and the vestibular end organs. As shown here, we inoculated the drugs through the posterior semicircular canal of the mice. So in this study, we use the social virus serotype 8, which harboring the green fluorescence protein sequence to evaluate the safety and the efficiency of canalostomy in the neonatal mice. We use the postnatal 1 to postnatal 2 age neonatal mice, and we inject the different reagents depending on different group, AAV8 GLP or normal saline, or no injection through the canalostomy. And about 30 days after the surgery, we performed the hearing test and the swing test in those mice. And after that, the mice were euthanized and for the immunofluorescence study. This slide shows the brief surgical procedures in the neonatal mice after a polyortical incision was made in the made, and we localized the semicircular canal, and then the soft tissues covering the canal was separated to expose the posterior semicircular canal, and we use 30G needles to make a tiny opening in the soft semicircular canal. Then we insert a cannula into the semicircular canal and deliver the virus into the inner ear of the mice. 30 days after the surgery, the hearing test data show that there's no significant difference in the among these groups in ABR threshold, and this one is AB1P1 amplitude, also in the DPOAE threshold. Okay, we also performed the swing test in those mice, and we didn't see any swimming disability in those mice, so which scored 0, suggesting a normal swimming ability. Then the inner ears was dissected out for the histoimmunostaining. Here is the whole mount of the organ of Corti. This column is a low mag image. Here is the high mag, and this is a merged image co-staining by the myosin 7-8, which is a nice marker for the head cells. You can see that 3 rows of outer head cell and 1 row of the inner head cell. From those data, we can see that the most of the inner head cells in apex, middle, and basal term successfully transduced by the virus, and in the basal term of the organ of Corti, a few outer head cells expressed the GLP. So we dissect out the lateral wall and also did the staining by the fluoriding, which shows the actin in the lateral wall. And we see that the marginal cells in the lateral wall express the GLP. So then in the how is the GLP expression in the vestibular end organs? So as shown in this slide, we can see that numerous GLP positive cells were formed in utricle, saccule, and ampulla. And the high magnification confocal images show that in both head cells and whole head cell layer and the supporting cell layer, we found extensive GLP expression, especially in the supporting cell layers. The transduction efficiency is very high. Interestingly, in the spiral ganglion neurons and the vestibular ganglion neurons, because as we know, the neurons is very difficult to be transduced by the virus, but with this approach, we found that both the spiral ganglion neurons and the vestibular ganglion neurons have a very high GLP expression efficiency. Here is the projection data of the confocal images, and we also have the Z-stack images of the different levels of the image. So to conclude our data, we show that the canalostomy in the neonatal mice result in minimal damage to the hearing and vestibular function. And this approach can get a wide distribution of the drugs in the inner ear in both cochlear and the vestibular and organs, and it may serve as a promising approach for the treatment of congenital cochlear vestibular diseases. Finally, I would like to thank Dr. Gong, my mentors, Dr. Liu, and our research team, and also Dr. Koffers, Dr. Raphael, our long-term cooperator from the University of Michigan. And I would like to thank the National Science Foundation of China to support this research. Thanks very much.
Thank you very much. Thanks for keeping the time. So we have a minute and a half for questions. Yeah, Chad?
Great talk. Why did you choose neonatal mice? Why not adult mice?
Oh, yeah, because a large portion of the disease are congenital, and we have to, if we wanted to treat this mice biologically, we have to treat the mice at a very early development stage. So compared to human, so we use the very young mice to inject to try to find a way to treat those kind of diseases. Yeah.
So obviously there will be many steps before clinical application.
Yeah.
But at what age do you think you would likely need to treat children at risk, for example, those with Usher?
Yeah, that's a fantastic question. Yeah, that's different from the children and the human and the mice. So for the translational aspects, I think the ideal way for the human is to treat the diseases during the embryo, like maybe 16 weeks. Yeah.
Great, thank you very much.
Thanks.
Can I just say something? It appears that Tim Williams received an email that he was not infected. That's why that wasn't on the cell after, but really sorry. Because his paper was on here. So he doesn't tell us.
Oh, sorry.
The other thing is I managed to program my phone now, so I'm going to make it.
Thank you.
No, it's 8 minutes, so he will know next.
Okay, today my topic is the neuroprotective effects of MK801 on auditory cortex in salicylate-induced tinnitus. I'm Yu Song from Peking University Third Hospital. I'm from China. Before we start, there is a question. If we met a patient with acute onset of tinnitus, no matter because of noise exposure, drug using, or other reasons, what should be the best timing to treat it? What should be the best time to put this stop button? To answer this question, let's go to my study. We know that tinnitus is a big problem both for patients and doctors. It will cause anxiety, depression, and insomnia, thus affect the quality of life of patients. However, the mechanism of tinnitus is now unknown, so the therapeutic strategies is still not so effective. There are many hypotheses, and one of them may be that the activation of NMDA receptors that will cause neuronal hyperactivity and neuronal excitotoxicity. But we would like to know what is going to happen during the tinnitus procedure. We would like to know the neuroactivity, the neurotransmitter, which is the glutamate, and also we would like to know another matter, which is the Ascorbate. It is an antioxidant, and also it is a neuromodulator it can be used in the glutamate ascorbate heteroexchange. We want to know how they are changing, and we would like to know if the AMD receptor antagonists will play some treatment. So here is what we did. We created the rat model of tinnitus by injecting salicylate into the abdomen of it, and we tested it by using startle reflex, which tell me that the rat is experiencing tinnitus. And we used the electrophysiological recording system to see you can see the spikes in here, to know the neural activity in there. And also we created another system. It's like this. We inserted a probe, the microdialysis probe into the cortex, and we used the pump into it, and the tube outside will contain the matter of the brain inside. And we use the electrochemical detector to know the concentration of the ascorbate, and another system of HPLC to detect the changing of glutamate. So here are the results. First, we detected the electrophysiologic measurement, and there are 4 groups. We can see the black one here. It shows it's increasing, which means that during the tinnitus procedure, the concentration, the neural activity is increased. And for the other 3 groups, we used MK801, 30 minutes before, 30 minutes post, and 60 minutes post. We can see that the increase is being depressed. And the earlier, the better. And then we detected the glutamate. It seems the same, and for the tinnitus group, we can see it's growing up. And for the other 3 groups, we can see it is greatly depressed. We can see in the bottom. And the one hour after, it is also being depressed, but not so well. And also we tested the ascorbate. The results showed similar. We can see from that it is increasing in the without intervention, but in the other 3 groups, we can see it is not going up so much. And 1 hour after, it is going up, but not so much. So let's go to our discussion. We can see that the auditory cortex of rats in salicylate-induced tinnitus, the neural activity is increased, and the glutamate is also increased, which tell us the activation of AMD receptors and glutamate-induced excitotoxic damage. As for ascorbate, it is also increased, because if it is a kind of antioxidant, and also it is a neuromodulator, we can say it's playing some role. But interestingly, we know that an AMD antagonist also plays some role. We can see that MK801 can significantly attenuate the negative effects induced by salicylate, only when it was given 30 minutes pre or post salicylate. If it is given 60 minutes after that, the elevation will be apparently reduced. So back to the question I mentioned before, if we met a patient with acute onset of tinnitus, it's better that we give them some treatment before that. For example, if we predict that for a worker who is doing some expulsion work, who will experience very large noise, so there is prediction that he will experience some hearing damage and tinnitus, so we can give him some treatment before that. And if we met some acute onset of tinnitus and we don't know the exact reason, it's best for me to treat as early as possible. Maybe not like this in the basic research, but clinically, maybe the earlier the better. So that's what I did. Thank you very much. Questions, please.
Done, thank you. So we have good timing for questions. Tim?
Thank you, very nice talk. How did you actually know that your rats had tinnitus?
Oh yes, there is actually the behavioral tests. Behavioral tests. We're now using the startle reflex. The startle reflex, it's a little bit complicated to explain, but if the rat is experiencing tinnitus, the reaction should be quite different from what they did before. So we tested it. And this, we used the injection of salicylate 350 milligram per kilometer, we can see that it will induce tinnitus almost 100%. Thank you.
We know from clinical experience that there is a self-healing reflex so that we can wait that the tinnitus heal in itself.
Yes.
How can you see it in your
Yes.
concept?
Yes. It's like this. We are now testing what is happening in the central nervous system. Usually we know that it will damage the hair cells, but we don't know what is happening in the central nervous system. We can see that there is neurotoxicity happening out in there. For some patients, maybe they can recover because our body, we have Ascorbate. We can help to recover, but for some other patients, maybe they are not so lucky. So maybe for some patients with very high risk of tinnitus, like what I mentioned, to experience some exposure work, or soldiers, maybe this kind of protective should be done, I think. Thank you.
Claire?
Do you think a salicylate-induced tinnitus model will be the same as a noise-induced tinnitus? Do you think it's the same pattern?
Well, that's really a very good question. Yes, it's quite maybe different because noise and salicylate, they are different. But for us, we can explain that in some drug-using patients, it's maybe like this. And for noise-using, it's almost the same because it will damage the hair cells and also affect the central nervous system. Ultimately, it's the same. The signals will go up to the auditory cortex. And we are exploring is what happened in the auditory cortex. I think it will give us some illustration, but you're right. If we do another experiment to create a noise-induced tinnitus model, it should be much better. Thank you.
Thank you very much. Thank you.
Thank you.
So next presenter is Dr. Nanoo.
Which one's your presentation?
Outcomes.
This one? Can I just ask you to put that in your pocket? Click that on your jacket.
Yeah.
So you can use clicker as well if you want.
Good afternoon, ladies and gentlemen. My name is Nanoo. I am an overseas trainee in ENT, currently based in Doncaster Royal Infirmary. Today, I would like to share with you our work looking at the outcomes of parotid surgery in a DGH setting. Just a bit of background. Salivary gland pathologies represent a histologically diverse group of lesions which can be non-neoplastic, neoplastic, which can be either benign or malignant. Going with the traditional teaching, I would like to mention regarding the rule of thumb, which says 80% of all salivary gland tumors occur in the parotid, 80% of all parotid tumors tend to be benign, and 80% of benign parotid tumors tend to be pleomorphic adenomas. Surgery remains the mainstay of treatment for parotid neoplasms, and the surgical aim would be complete excision of the lesion. During the procedure, facial nerve is at risk, and great care is taken to preserve the nerve anatomically and functionally. Nerve monitoring has become a standard of care during parotid surgeries, whether it is primary or revision. So apart from facial weakness, other complications can be seromas, hematomas, wound infections, Frey syndrome, salivary fistulas, or even recurrence. The expected standards would be a wound infection rate of less than 20%, permanent facial palsy of less than 10%, temporary facial weakness of less than 60%, and a seroma of less than 40%. The aim of our study was to evaluate the surgical outcome in all patients who underwent parotid exploration under a single surgeon, Mr. Qureshi. We had 338 consecutive parotidectomies in 336 patients over the last 14 years. We retrospectively reviewed the patient notes and collected data pertaining to patient demographics, investigations, clinical pathological parameters, and perioperative morbidity. So our study group consisted of 336 patients who had parotid operations between April 2004 to November 2018. Looking at the results, of the 336 patients, 2 patients were operated bilaterally. 1 patient had bilateral Wathens, while other patient had Wathens on one side and pleomorphic on the other side. This line graph represents the number of operations performed each year, making an average of 24 a year. The age of the patient ranged from 16 to 89 years with a mean of 55 years. The mean duration of the lesion noticed by the patient prior to presentation was nearly 2 years. The size of the lesion ranged from 0.4 to 35 centimeters with a mean of 2.6. This was the largest lesion excised, which weighed nearly 2 kilos. This was reported in press all over UK. She underwent a total conservative parotidectomy with no residual facial weakness. 54% of our patients were males, the rest were females. 53% of the lesions were seen on the left, the remaining on the right. Smoking history was also considered, but was found to be significant only in Wharton's. Coming to the final histology, excluding the benign cyst under the non-neoplastic lesions, nearly 87% of the lesions were neoplastic, of which only 96% were benign and only 4% malignant. This disparity from the rule of thumb was possibly because of the referral of malignant cases to Sheffield for treatment. And of the benign, only 60% were pleomorphic and 35% were Wharton's. These were the other benign lesions, which included a few of the intraparotid lymph nodes, parotid calculi, and few other benign tumors. And the malignant lesions on final histology are as listed in the table. Considering the age versus pathology, we found that majority of our patients with the neoplastic lesions belonged to the age of 40 to 80 years with an increasing risk of malignancy with increasing age. FNA was performed in most of the patients, and in majority of them, FNA agreed with the final histology. Considering the specific histology type, FNA was 83% accurate in detecting pleomorphic adenomas and only 64% of Wharton's. In nearly 300 patients, some sort of imaging was performed, either ultrasound, CT, or MRI. 89 patients had a combination of two modalities. MRI is considered to be the imaging of choice, especially if deep lobe tumor is suspected, and CT was performed only if MRI was contraindicated. So normally, we arrange the first postoperative visit at 6 to 8 weeks, and if the histology is benign and no postoperative complications, we tend to discharge the patient at the second visit. Of the 338, 128 patients had postoperative complications. A few had 2 or more minor complications. So it is evident nearly 113 patients had facial weakness postoperatively, and more than 99% recovered completely. The incidence of seroma was quite high during the initial part of the study, which possibly was attributed to the use of Surgicel to the tumor bed. But for the last 3 to 4 years, the incidence of seroma has come down to nil. Postoperatively, facial nerve function was recorded in all patients, and any weakness noted, whether it involved the upper, lower, or both divisions. As you can see, majority of our patients with the facial weakness had involvement of only the lower division, that is the marginal mandibular. And of the 113 patients, nearly 107 patients recovered completely by the time of their first follow-up. Only one patient had a residual facial weakness, that too involving only the marginal mandibular division. Of all the facial weakness, one would expect the deep lobe involvement to cause a higher risk of facial weakness, but the size matters rather than the location of the lesion. From the table, it is evident that majority of our patients, nearly 60%, with facial weakness had involvement of only the superficial lobe, and 30% had involvement of the deep lobe. Now, of the superficial, 82%, and of the deep, 90% patients had tumor more than or equal to 2 centimeters in size. Most of the studies report nearly 90% of facial nerve weakness recovery within the first year, and the incidence of Frey syndrome have to be reported as high as 97%. This actually depends on how long the patient is being followed up. The outcome rates of our study group were comparable with the published data. You can see the incidence of facial weakness was quite low, and we didn't have any permanent complete facial palsy, and less than 1% of facial weakness, which involved only the marginal mandibular. Quoting a few studies which compare the risk of permanent and temporary facial weakness with the present study. So to conclude with, our outcome rates were within the expected standards. More than 90% of the lesions were benign, possibly because of the referral of the malignant ones. Wharton's tumor appeared to be more common, which could be attributed to the aging population. Facial weakness or paresis is quite unavoidable, but complete recovery can be expected within the first few months. The larger the size of the lesion, higher the risk of complications, but meticulous dissection helps to reduce the risk. These are my references. Thank you.
Good, thank you very much. We've got 2 minutes for questions.
Yes.
Thank you. It's great to have a series over such a long length of time with such good numbers. Were you able to see if there are any trends over time with outcomes or related to a change in technique? Did you look at sort of that at all?
Yeah, facial weakness was quite common during the initial part of the study. And as I mentioned, the incidence of seroma was quite high during the initial part of the study. But over the last 3 to 4 years, once the surgeon noticed that using the Surgicel was a high risk for producing seromas, he stopped using it. And now we don't have any seromas.
Any other questions? It's nice to be able to keep the data for that long anyway. So that's a good deal.
Thank you.
Nice. Thank you very much. So our next presenter.
Yes, let's put that in your pocket. Just stick that on your jacket as well. Put that there.
No. Good afternoon, ladies and gentlemen. My name is Al-lami. I'm one of the ear, nose, and throat registrars. I work in the Kent, Surrey, and Sussex deanery. I would like to thank Prof. Qureshi for the invitation to present my talk. This is a study evaluating the effects of throat packs during nasal surgery. It's a randomized control trial of multidisciplinary nature with the ENT team and the anesthetic team. Throat packs recently become quite a topical subject. It's basically involved with multiple colleges, with the Royal College of Anaesthetists, as well as the ENT UK and the Oral and Maxillofacial Association, where there recently been a meta-analysis that has influenced the guidelines for the anesthetics, and I will go through things in time. And it also nicely brings it on to the end of the morning session, since it's a rhinology-themed day. So what I've done in the study is essentially throat pack is a swab or gauze used to occlude the oropharynx that was done in the nasal surgery time. The purpose of it is to protect the aerodigestive tract so that from secretions of blood going into the airway, as well as blood secretions going to the esophagus and going to the stomach. The main purported benefit is to reduce postoperative nausea and vomiting and reduce airway morbidity. That's the rationale really for insertion them. In terms of main drawbacks for them, throat pain has been reported, has been in the 1970s, has been reported with an incidence of 15 to 61% risk of throat pain from the throat pack insertion. The other throat packs are mucosal injury and retained packs. Retained packs is a never event, and in the NHS England, there was 21 cases reported of never events from 2013-2016. And also there was one report of death from throat pack and causing airway obstruction. So it's a serious topic, and therefore, potentially we could minimize patient morbidity with this. Recent review of the literature highlighted there's basically a lot of literature that was addressing side effects of the throat packs, not many that actually address the benefits of the throat packs in terms of data, but essentially the main outcome of the review is that there was a lot of methodological flaws in the studies, and not many of the studies were including high blood contaminating procedures. So the systemic review was recently published by the Royal College of Surgeons, showed that there's no evidence from the pack, but also welcomed randomized control trial to address the topic. So the main objective of the study is to identify if there is any difference between a throat pack group and a non-throat pack group. The second outcome measure was a difference in throat pain between the two groups. And also we looked at for any evidence of airway morbidity and any complications of pneumonia with later admission. So this is a multidisciplinary team study that was done over a 2-year period. So anyone want to embark on a randomized control trial, they need time. It took 2 years between the research proposal to actually getting the data. What we included is all the nasal surgeries that are listed here. And essentially the exclusion criteria for that is malignant disease or patient with a history of nausea and vomiting. We thought that these surgeries represent most of the rhinology units that would offer rhinology service. We use the local university for a help with the statistics, and their recommendation was a power calculation of 80 patients, 14 each group, to get adequately powered study. The anesthesia was standardized with all received endotracheal intubation. There was no antiemetic and no long-acting opiates were used intraoperatively, and no dexamethasone, which is commonly practiced in many units, was not given during that surgery. And for the purpose of analgesia, paracetamol and non-steroidals were used. So what we use for the collection of the data, we use the pain scores. We're using a VAS analog scale from between 0 to 10 up to 1 decimal point, and that was done at 2 hours, recovery, 2 hours and 6 hours after the surgery. And in terms of the postoperative nausea and vomiting, we use this scale, this validated score, which basically gives a score of up to 50. If you've had 3 or more episodes of dry retching and vomiting, that straight away gives you a score of 50. If you've had nausea all the time, that gives you a score of 50. But otherwise, the score will be multiplied between all of them to give you a final score out of 50. In terms of the results, so these are the results that we got from our cohort. This was essentially what we aim to do with the randomization, is trying to see if we can actually get 2 equal arms in terms of blood-losing surgery and blood-sparing surgery, blood-losing being, for example, a FES, blood-sparing more of a septoplasty, and we wanted to see if they actually sort of corroborate between the two. There were more male in the non-PAC group, but that really hopefully shouldn't have much impact on the results. So in terms of the data, what we got, this is the statistical analysis. What we use is a Mann-Whitney test. We got non-parametric results once we've actually analyzed it. Initially, when we did the power calculation, it was on t-test, but it was presumed to be parametric, but we got non-parametric results. So again, both of these scores are low. The throat pack actually surprisingly had more throat pain compared to, more postoperative nausea and vomiting compared to non-throat pack group. The reason being, you had 2 outliers who actually scored 50 in the throat pack group in terms of postoperative nausea and vomiting. This were the mean scores for the pain, so you can appreciate that's a little bit higher on the recovery, but fairly equal in the 2 hours and 6 hours postoperatively. In terms of the median score, because we've got non-parametric results, and best to elaborate with the median score, again, fairly similar on both sides. And once we've put this through statistical analysis, the only significant finding in terms of statistically significant result was the pain and recovery. It was higher in the throat pack group. In terms of the postoperative nausea and vomiting, they were actually fairly equal, but there was no statistical significance. Again, the high standard deviation was because of the 2 outliers in the postoperative nausea and vomiting group, the throat pack. So in terms of the limitations of the study, is from an anesthetic point of view, speaking to the different anesthetists, they were not blinded. The surgeon was blinded, the assessor was blinded, the patient was blinded, but they were not blinded. In the study, we used endotracheal tube. Most rhinology units, they offer LMA nowadays, but we felt the LMA, because it's bigger size, may have an impact on the throat pain, and hence that's the rationale for endotracheal tube. The other thing is, how accurate are really patients giving you the results in recovery? We try to do that as more they're awake. So again, that's something to be limited for the study, and we didn't use dexamethasone. And it's a wide range of rhinological procedures because, like I said, it's more to be representative of what rhinology units tend to offer. Where does our study fit in the literature? It corroborates most of the data that's available. The recent guidelines from the Royal College of Anaesthetists actually discouraged throat packs because there was no benefit and was more harm was used. And to conclude, my study showed no difference in terms of postoperative nausea and vomiting in the throat pack versus no throat pack group. In recovery, there was more pain associated with throat pack. There was no airway morbidity. And generally speaking, the throat packs and nasal surgery did not lower the risk of postoperative nausea and vomiting, but potentially cause more pain. And this can have an impact in terms of patient morbidity, delay in surgery, and also patient safety aspect. I would like to thank my colleagues for their help with the study, and these are the references I've used. Happy to take any questions.
So thank you for keeping the time as well. So we've got 2 minutes for questions. Tim?
You didn't mention it, but did you have ethical committee approval for that talk?
I did, yeah. It took a bit of time, but before we started with the research proposal and we got ethical.
The big problem is the airway problem, isn't it? Because all it takes is one airway problem. You know, I accept all the other things, but I find it very difficult to do a septorhinoplasty, where you occasionally, even with the best exercise, pretty significant bleeding without airway protection. It just takes one case where you have, I don't know how much protection a throat pack gives to bleeding down the airway with the tube down.
Yeah.
I don't know the answer to that.
Indeed.
You said that there's been a death in a patient having dental anaesthesia where they extubated the patient left the throat pack.
Yeah.
There's one death from the retained throat pack.
Well, anaesthetist doesn't use them.
Yeah. And that was a recommendation from the Royal College, actually, because there's no evidence of benefit anywhere written in the literature. There's more of a teaching down the line of concern about the airway, hence why there's now discouraged.
Can I have an interesting thing? You mentioned that tubes can cause less pain than the laryngeal mask, but the trend is probably the opposite. Really, we think so anyway.
I think from
our papers, did you find any papers on that?
I didn't actually address in terms of Al-lami, but the rationale behind it was because the Al-lami takes bigger space in the throat, so therefore potentially could have an impact in terms of the throat pain, whether it's related to the Al-lami or the actual
so you
throat
haven't
pack.
seen papers.
I haven't seen the paper.
We all feel tubes cause more pain, and that's our experience in general. But I don't think there's papers in literature anymore. Yeah, Claire.
Did you standardise for topical preparation? Because we find if we have an anaesthetist who doesn't use an aerosol device for our Moffitt solution, and we get a lot of pooling of cocaine in the postnatal space, those patients get a lot more pain from vasoconstriction.
Indeed.
Was that standard technique in preparation using?
Yeah, we standardize it for all. They all receive Moffitt solution, so whether throat pack or no throat pack group. One of the rationale for inserting throat pack is that picks up all these vasoconstrictors that can trickle down the back of the throat. Again, there was not much evidence on it, but yeah, we standardize it for all patient.
Good. I think we've run out of time now. Thank you very much.
Thank you.
All done. Now, don't go yet. We're going to show you the launch the journal.
Yeah. Yes.
Is that connected?
Have we got the internet here? Yes. Just website.
Yeah, just put me through the Masterclass website. Yeah. Okay. So we normally launch a journal in this course every year. In the past, this is number 11. This is the 11th edition. For the last 10 years, we published about 2,000 paper editions. And we later on, after we distributed them everywhere, we put it online. That was expensive and also didn't go everywhere. So we decided now, with the technology available, that we'll be able to put it online immediately. And it's available to everybody. And also it's going to help us to do lots of other things, like, for example, putting videos. So the journal is available from now. All you have to do is to go to ENT Masterclass website and go to Journals and Text. All the previous ones are here, as you can see. And this is the new one. You just click on it. And it will appear straight away with the cover. And then you can follow it. Here is the index, editorial, then all the papers, and then the presentations from last year, they'll be here in the abstracts. So that starts with the editorial, and you can just follow the index. All the articles are organized that way. We don't put them like pediatric together, head and neck together. It's organized in a different way. So it covers the 4 areas of ENT. So you can see here the pediatric ones, and so on. You've got the colors and everything. So the quality is really clear. So I think that's a better way of everybody having access to the journal. So anybody who wants to read this article, they're all there. Something else we're thinking about is probably add articles on the go. So we may do this as well. That's available for us because it's just there. We can add some more articles. But in general, we're going to launch a journal in January at the beginning of every year as before anyway. So that's it really. So anybody who wants to have a read, it's there already. And all the previous ones. Now it's lunch.